Welcome, everyone, to Co-occurring Disorders in Practice, Integrated Care, Harm Reduction, and Real-World Tools. This training is for all of us at JADE, not just therapists, but support staff, medical staff, recovery specialists, and administrators. Every single role here touches the lives of our clients, and every role matters in how we deliver care. So, over the next hour, we are going to explore what co-occurring disorders are, why integrated treatment is essential, and how each of us can contribute to making JADE a place where clients can feel seen and supported. And by the end of this training, you'll be able to explain what co-occurring disorders mean and why separating mental health and substance use doesn't reflect most clients' lived experiences or needs. You'll be able to understand the principles of effective integrated treatment and how harm reduction fits into our approach at JADE. And you'll be able to recognize how cultural humility, language, and stigma impact client care. You'll see where JADE fits compared to other programs and why our model is uniquely suited to serve clients with both substance use and mental health needs. And you're going to be able to apply real world tools and strategies that align with your role, whether you're answering phones, running groups, prescribing medications, or offering recovery support. So let's start with a basic definition of what we mean when we say co-occurring disorders, or CODs, is how you'll see it abbreviated in the slide deck. We're talking about when a person is experiencing both a substance use disorder and at least one mental health disorder. This could be something like depression and alcohol use, or PTSD and opioid use. And for many people we serve, these struggles don't exist in neat, separate boxes. They're woven together in everyday life. And that's why integrated treatment matters. Historically, substance use and mental health were treated in totally separate systems. A client might have to go to one program for mental health therapy and another for addiction counseling, with providers who rarely talk to each other. At JADE, we're committed to being different. Our mission is to provide the highest quality, ethically grounded, and compassionate care for individuals living with both substance use and mental health disorders. We believe in the power of integrated treatment, combining medical, clinical, and peer driven approaches to support healing of the body, mind, and spirit. And I've put a copy of our mission statement on this slide so that you can look through it and get a feel for what I mean by that. So here's something really important to clarify. JADE is not just substance use disorder treatment. We are a co-occurring disorder treatment center, and that means that we're built to support people who have both substance use disorders and mental health needs. This is a different approach from other places, which might be just a mental health program that might also treat substance use if the substance use is stable, or other substance use treatment programs that don't treat mental health at all. JADE, on the other hand, takes the opposite focus. We are licensed as primary substance use treatment, but we are equipped to address mental health right alongside it. Now, you might have heard terms like primary and secondary diagnosis, and those words come up a lot in the DSM and in insurance paperwork. But here's the thing, from a co occurring lens, primary and secondary don't always make sense. For the person sitting in front of us, their depression, their anxiety, and their drinking don't feel like separate categories. They feel like one interconnected experience of suffering and coping. And honestly, it can be hard even for professionals to suss out what came first or what's driving what. And that's okay. What matters more than pinning down a hierarchy of diagnoses is asking, what does this person need? And how can we as a program help them meet those needs? And that's where Jade's different. We bring interdisciplinary teamwork, therapists, recovery specialists, prescribers, nurses, admin staff, and support staff all working together. We bring compassion with accountability. We love our clients enough to hold them to expectations while also understanding setbacks as part of recovery. And we bring a holistic lens, always looking at the whole person rather than reducing them to a diagnosis. Throughout this training, I'll be weaving in examples from Jade's own practice so that you can connect the ideas we're talking about with the real work that you do here every day. So, we're going to go deeper into what co occurring disorders are in practice, how they look, how they overlap, and why it can be hard to tell what's what and why that's okay. So, let's start by setting some shared language. And these are terms that we'll use often. So, when we say them, we all mean the same thing. And starting with substance use disorder. So, when someone uses substances like alcohol, opioids, stimulants in a way that causes harm, so that might be health, social, occupational, or legal, and they're using ongoingly despite that harm, they would likely qualify for a substance use disorder. Now, a mental health disorder is conditions like depression, anxiety, PTSD, bipolar, schizophrenia, things like that. So, those are things that affect thinking, mood, behavior, and capacity to cope with daily life. And then we've got co-occurring disorders. So that's when a person has both a substance use disorder and at least one mental health disorder, either at the same time or overlapping significantly, such that each condition influences the other. So that's the preferred term today is co-occurring disorders. Dual diagnosis is an older term that you might still see in some paperwork or read or see online, or maybe even hear in conversation. And it usually meant the same thing as co occurring disorders, but it's fallen out of favor. So you might ask why? Well, because dual suggests that a person only has two disorders, when in reality, people may experience multiple mental health concerns alongside multiple substance use concerns. So the term also made it sound like there were only two neat boxes, when in practice, symptoms are messy and interconnected. And that's why co occurring disorders is the most accurate and respectful term now. It captures the full picture without limiting or oversimplifying somebody's experience. So let's think about a real world example for a second. So just imagine a client, we'll just call him Jordan. Jordan drinks heavily, especially when feeling anxious in social situations. They also have flashbacks from a past trauma and struggle with depressive episodes that make it hard to get out of bed some days. So if we're using the old term dual diagnosis, we might say Jordan has an alcohol use disorder and depression, two diagnoses. But that leaves out the PTSD, and it doesn't really affect how all three conditions overlap and feed into each other. Calling it a co occurring disorder better respects the reality that Jordan's struggles are interconnected and don't neatly fit into only two boxes. So, one of the biggest reasons co occurring disorders can be challenging is that so many symptoms overlap. For example, things like difficulty sleeping, changes in mood, problems with concentration, irritability, or even social withdrawal can all show up in different ways. These symptoms might be caused by substance effects, withdrawal, a mental health condition like trauma, depression, or even physical health issues like untreated thyroid problems, chronic pain, or even sleep apnea. Because of this overlap, it's not always easy to say this is definitely a mental health issue or this is definitely substance related. This is where the idea of differential diagnosis comes in. Differential diagnosis simply means that slowing down to consider different possible explanations for what we're seeing and asking questions to better understand the full picture. Some of the questions that help us sort this out include: when did the symptoms begin relative to the substance use? So, for example, did the depression symptoms show up years before alcohol use or mainly during withdrawal periods? Are symptoms present even after acute intoxication or withdrawal has passed? So, if anxiety is still there weeks after sobriety, it might point to an underlying anxiety disorder. Could trauma or chronic stress be contributing? Trauma symptoms can mimic or amplify both substance use and mental health challenges. And are there medical or physical causes that need ruling out? Sometimes thyroid disorders, chronic pain, head injuries, or sleep disorders like sleep apnea can create symptoms that look like depression, anxiety, or even withdrawal. So it's important to remember that these tools don't give us a perfect answer every time. Our goal is not to nail down whether something is only a mental health issue or only substance use. Instead, our goal is to understand enough so that treatment planning is meaningful and holistic. And that might mean treating symptoms on both sides at once, addressing health issues and supporting the person as a whole, not just reducing them to one diagnosis. For clients, this often feels really validating. Many of them already know that their struggles don't fit neatly into separate categories or even just one category. By acknowledging that overlap, we show them that we're listening to their lived experience and not just checking boxes. So here's where nuance and honesty comes in. Clients don't often come to us with neat stories about what came first, and that's okay. Many clinicians believe primary versus secondary diagnosis distinctions are less useful than they once were, especially for guiding care. So we want to avoid pathologizing somebody if we aren't sure what's primary. We want to be transparent with clients. If we don't know exactly what came first, that doesn't block us from helping them with both. And we want to use assessments, collateral information, and sometimes a little time to see how things evolve, all while still delivering quality care. And to really understand co occurring disorders, we need to step back and think about why people use substances in the first place. Two authors in particular help us understand this a little bit more. So there's Dr. Gabor Mate and Maya Salovitz. Dr. Mate is a Canadian physician who's worked for decades with people experiencing homelessness, trauma, and severe addiction. And in his book, In the Realm of Hungry Ghosts, he argues that addiction is not simply a disease or a series of bad choices. Instead, it's often a response to deep pain, past trauma, attachment injuries, stress, loss, and neglect. Substances become a way to soothe, to numb, or to survive emotions that otherwise feel overwhelming. And Maya Solovitz is a journalist and author who's written extensively on addiction and harm reduction. In her book, Undoing Drugs, she tells the story of harm reduction in the United States and makes a similar point. People use substances because at least at some point it works for them. Drugs or alcohol help them feel less anxious, more connected, less haunted by trauma, or more in control of their world. While their coping strategy is harmful in the long run, it starts as an attempt to manage pain. So, some key points to keep in mind here. Trauma often comes first. Many people who develop substance use disorders have histories of trauma or adverse childhood experiences. That trauma doesn't disappear when somebody starts treatment. It shows up as depression, anxiety, or PTSD, and it often fuels substance use. We also want to remember that their patterns of use are going to tell a story. The frequency, type of substance, and even the rituals around the use can reveal what a person is trying to manage. For example, somebody using opioids may be seeking relief from emotional and physical pain, while somebody using stimulants might be trying to fight through depression or exhaustion. Ignoring the trauma misses the point. If we only focus on the substance use without addressing what's underneath, we risk missing what the client is truly trying to survive. This can make treatment feel hollow or even unsafe. On the other hand, when we integrate trauma informed care, which means asking what happened to you instead of what's wrong with you, clients are more likely to feel safe, understood, and engaged in treatment. At JADE, this means that our work is not just about reducing substance use or stabilizing symptoms. It's about recognizing that each person sitting across from us is carrying a story of pain and resilience. Whether you're a counselor, a recovery specialist, a nurse, or the first face that a client sees at the front desk, how we interact with them can either reinforce shame or open the door to healing. So you might hear people say that co-occurring disorders are common or frequent, but it helps to see how common in numbers. These statistics are more than just numbers. They do reflect what many of our clients already experience before they even walk through the door at Jade. I have some stats here, and as of recording this in September 2025, these were the most recent numbers. Hey, research takes time, so just bear with me. According to the National Institute on Drug Abuse, or NIDA, in 2019, they found that about 35% of United States adults with any mental illness also have a substance use disorder. So this shows how much the two overlap in the general population. And then SAMHSA's 2022 National Survey on Drug Use and Health reports that nearly 50% of adults with a substance use disorder also had a mental illness. In other words, about half of people with substance use disorders are also living with co-occurring mental health conditions. In 2022, an estimated 21.5 million adults in the United States lived with both mental health disorder and a substance use disorder. That's about 8.4% of the entire adult population. And here's another important piece to consider. Not everybody with a mental health or substance use disorder will seek treatment, but among the people who do enter treatment, co-occurring disorders are even more common. SAMHSA data shows that over 60% of adults in addiction treatment also meet criteria for at least one mental health disorder. And the reverse is true in mental health settings. Many clients also meet criteria for a substance use disorder. So, in other words, when we're working in treatment settings like JADE, we should expect that co occurring disorders are the norm. Shared risk factors like trauma, stress, poverty, genetics, or systemic inequalities mean that one condition often increases the likelihood of the other. So it's not a matter of if a client has a co-occurring mental health and substance use issue. It's more of how many, how severe, and what kind. Many clients will come through our doors already carrying symptoms of both, even if only one has been diagnosed or treated so far. Because co-occurring disorders are so common, everybody's role matters. Front desk, recovery specialists, prescribing providers, therapists, all of us will encounter clients whose mental health and substance use are intertwined. So, because symptoms overlap, uncertainties are going to be normal. Our assessments and treatment plans must allow for ambiguity. We need to approach clients with humility. They often know parts of the stories that we don't. And again, they're the experts on themselves. Our interventions must consider trauma, use a holistic view, and not just treat symptom A in a vacuum. All of us, no matter what role, are part of this. Setting a safe environment, noticing when mental health might be involved, and supporting integrated care rather than reinforcing siloed treatment. When we talk about principles of care for co occurring disorders, we're really talking about the values and approaches that guide everything that we do at JADE across all roles. These principles are not just for therapists or prescribers, they shape how every single staff member interacts with clients from the front desk to the recovery house to the therapy room. So let's break this down. Integrated means that we don't split people into categories like mental health on one side and substance use on the other. Instead, we treat the whole person, recognizing how these issues interact. For example, if a client reports panic attacks and is also misusing benzodiazepines, we don't only address the panic or the misuse, we address both together. Trauma informed care means that we recognize that most clients have experienced some form of trauma, whether childhood neglect, violence, loss, or systemic oppression. Trauma informed practice is not a specific therapy technique, it's a way of showing up. For therapists, it might mean pacing sessions carefully so clients don't get overwhelmed. For medical staff, it could mean explaining each step of a procedure or medication change so that clients feel safe and informed. For front desk staff, it may look like greeting clients warmly and respectfully, knowing the first few minutes of contact can set the tone for whether someone feels judged or welcome. For recovery specialists, it might mean meeting clients where they're at, showing respect even when they're struggling, and modeling hope. And recovery oriented care means believing recovery is possible, even when it doesn't look linear. It's about focusing on client strengths, building resilience, and honoring their goals, not just avoiding relapse. Recovery is not a one size fits all, it's personal, and our job is to support it in whatever shape it takes. And moving on to talking about harm reduction and any positive change. So, harm reduction is often misunderstood as being only about medication assisted treatment or MAT, like methadone, buprenorphine, or naltrexone. MAT is a critical piece of harm reduction, but the philosophy goes far beyond medications. At its core, harm reduction means that we honor and support any positive change a client is willing or able to make, even if they're not ready or don't want to stop using completely. For substance use, harm reduction might mean a client cutting down drinking from daily to weekends, or somebody using clean syringes instead of reusing old ones, or a person carrying naloxone or even fentanyl chest strips with them, or maybe choosing MAT to stabilize cravings and reduce overdose risk. For mental health, harm reduction might look like a client showing up for group, even if they don't talk much yet, or somebody starting an antidepressant, even if they're unsure about staying on it long term. It might look like practicing a coping skill once a week. It might look like using grounding skills some of the time or replacing self harm with some safer coping strategies. Every small step counts, and we're here to celebrate those steps. We create space for bigger changes down the line. Talking about patient centered language, our words matter. They can either reinforce stigma or promote dignity and healing. Instead of relapse, we say recurrence. Relapse can carry shame. Reoccurrence normalizes the reality that recovery often involves ups and downs. Instead of describing urine screens as clean or dirty, we can use the words positive or negative. That's neutral, it's factual, it's not moral. And instead of pass or fail, we simply can focus on results and focus on next steps. Patient centered language means removing judgment and values based terms from our communication. It's not about being politically correct. It's about speaking in ways that reduce shame and help clients stay engaged. As far as guiding principles for co occurring disorder treatment, the big takeaways are that we're going to treat both disorders as equally important. Don't ignore mental health to focus solely on substance use or vice versa. We're going to see the whole person, not just symptoms. Clients are more than diagnoses or behaviors. They are people with values, strengths, and goals. Change often happens step by step. Meet clients where they are and help them move forward at a pace that makes sense. And we're going to expect reoccurrence. Co-occurring disorder treatment isn't about perfection. It's about progress, learning, and resilience. And finally, collaboration is key. Co-occurring disorder care requires teamwork between staff roles, with families, and with the clients themselves as active partners. At JADE, these principles are the backbone of our model. They're how we distinguish ourselves from other agencies, and they remind us that every staff member, regardless of role, is part of creating an environment that's integrated, trauma informed, recovery oriented, harm reduction focused, and rooted in dignity. One of the most helpful frameworks for understanding client engagement is the stages of change. And this is a model that was developed by psychologists James Prochaska and Carlo Di Clemente. This model helps us recognize that change is a process, not a one time event. People move through stages at their own pace, and they may be in different stages for different issues all at once. So the actual stages are pre-contemplation, contemplation, preparation, or sometimes that stage is also called determination. There's action, there's maintenance, and there's reoccurrence, or you might see it being referred to as relapse. In pre-contemplation, a person isn't yet considering change, or they may not see their behavior as a problem. In contemplation, there's aware that there's an issue, but they might feel ambivalent or torn. They may see reasons to change, but there's also reasons to stay the same. In preparation, they've decided that change is important and they're starting to plan, like exploring options or setting a quick date. In action, they're actively taking steps to change their behavior. And then in maintenance, they've made changes and are working to sustain them, learning coping strategies and building support. And generally, the difference between action and maintenance is about 6 months. So, to be in maintenance, you generally have to have already been in action and been able to sustain action for at least 6 months to get to maintenance. And then maintenance would be everything after that, as long as the change is sustained. And then reoccurrence, they're going to return to old behaviors or symptoms. Instead of treating this as a failure, it's seen as part of the process, a chance to learn what went wrong and what might help next time. So it's important to remember that clients can be in different stages for different things at the same time. So, for example, somebody might be in action with opioid use, taking medication assisted treatment and attending groups, not using. And then they might also be in contemplation about their alcohol use. They're seeing the pros and the cons, but they're not really sure about if they want to stop drinking or not, or even want to cut back. They might also be in preparation for their depression. That might look like researching or talking about starting SSRIs to help them, but they haven't necessarily actually started any medications yet. And all at the same time, they could be in pre contemplation about some unresolved grief or trauma. They're just not ready to address it yet. So, this is really normal and explains why treatment doesn't always feel linear because people are moving at different stages at different times for different things going on in their lives. And our interventions are most effective when they fit the stage that the client is in. And this is really what it means to meet the client where they're at. So, identifying the stages that they're in and then choosing an intervention to meet them there. In pre contemplation, staff can work to raise awareness, provide information, and show acceptance of their process. In contemplation, it helps to explore ambivalence. What are the pros, what are the cons, or what might they imagine life would look like with and without change? In preparation, we can help them identify supports, coping skills, and realistic goals. In action, staff can cheerlead, troubleshoot barriers, and reinforce progress. In maintenance, it's about supporting long term coping strategies and community connections. And then in reoccurrence, staff can reframe the experience as a learning opportunity, not a failure. This is why one size fits all interventions don't work. Meeting somebody where they are is key. And sometimes we even describe clients as being resistant. From a motivational interviewing perspective, resistance is not a personality trait, it's a signal. It usually means that the approach that we're taking doesn't fit where the client is in their process. If we push too hard, too fast, clients can push back. Or if we're using action stage of change interventions when somebody's in contemplation, it's going to fall flat. Motivational interviewing encourages us to view this not as defiance, but as ambivalence, a natural part of change. Ambivalence means that somebody feels pulled in two directions, wanting to change and not wanting to change. It's like being stuck between a rock and a hard place. So, for example, if I quit drinking, I'll lose my coping tool. But if I keep drinking, I'll lose my jobs and my relationships. What do I do? So, motivational interviewing is a counseling style developed by William Miller and Stephen Rolnick. And at its heart, it's about collaboration, respect, and evoking the client's own reason for change. It's not about persuading or lecturing. Motivational interviewing is built on four key skills, and they're often remembered as OARS skills, OARS, open ended questions, affirmations, reflections, and summaries. So, for open ended questions, we're going to invite the client to share their perspective. Affirmations are recognizing their strengths and their efforts. Reflections mirror back what the client says to show understanding and to help them hear their own words. And then summaries pull things together to highlight their motivations. Why does MI matter here? Because co occurring disorder clients often feel shame, stigma, and pressure. Motivational interviewing reduces defensiveness, builds trust, and helps clients move through ambivalence at their own pace. So, in addition to motivational interviewing, we can also use harm reduction as a bridge for ambivalence. When clients are ambivalent, both wanting change and fearing it, harm reduction gives us a middle ground. Instead of saying, change everything right now, harm reduction allows clients to take smaller, safer steps. So, some examples might include cutting down rather than quitting immediately, switching from injecting to safer methods, using prescribed medication to reduce cravings or to stabilize mood, and engaging in therapy once a month instead of weekly, just to test the waters, just to see how it feels. For clients, harm reduction can feel less overwhelming and more achievable. It's a way of saying, you don't have to have it all figured out. Any step towards safety and health counts. So I want to hit us with a case vignette right here and talk about Maria. So she is a 34-year-old woman who's been coming to Jade for a few months. She's been on buprenorphine and says that it's helped her get through the day without worrying about withdrawal. She still drinks most nights after work, though looks that wine is the only thing that makes her feel calm. Maria has struggled with depression for years, and she recently scheduled her first psychiatry appointment to talk about medications. When her therapist brings up past trauma, Maria shuts down quickly and says, I'm not talking about that. I can't. But she lights up when she talks about her kids. She tells staff that she wants to be around for them and mentions maybe going back to school to finish her GED, something that she never thought about until she started feeling more stable. So I want you to just to take a moment here, just pause and think. Maria is juggling several different processes of change at once. What did you hear? What is the change that's going on? And where do you think she is in the stages for each of these? So you might want to consider her opioid use, her alcohol use, her depression, her trauma history, and even her interest in finishing her GED. Clients rarely move through just one clear change at a time. Part of our role of staff is to recognize the multiple change processes happening all at once, even the ones that don't scream treatment on the surface. Sometimes the motivation to change in one area, like education or parenting, becomes the fuel for change in substance use or mental health down the road. So if you need more time, you can just pause the video here. The next slide, we're going to move on to talk about what stages of change Maria might be in. So for opioid use, Maria appears to be in the action stage of change. She's consistently taking buprenorphine, which shows she's already made a clear change and is actively working to sustain it. We don't know how long she's been doing it. It's possible she could even be in maintenance if she's been doing this for over 6 months and has been able to stay away from opioid use. For alcohol use, she seems to be in contemplation. She knows it's interfering with her health, but she also sees it as her main way to relax. That tension is the hallmark of contemplation. For depression, Maria seems to be in preparation. She hasn't started the antidepressants yet, but she's scheduled for an appointment and is taking steps to explore her options. And for her trauma history, it seems like she's in pre contemplation. She's not ready to talk about it, and that's important for us to respect. The door can stay open without pushing her through it. And for that last one, the curveball, the GED, she's actually in contemplation or preparation. So she's not enrolled in classes yet, but she's thinking seriously about it and starting to connect the dots between her stability and wanting to move forward in her life. This exercise shows us how layered change really is. Clients don't neatly fit into one stage across all areas. Our job isn't to rush them into action everywhere, but to recognize where they are in each process and respond in ways that make sense for that stage. So you can pause here again, and now that you know where she's at in each stage of change, you can consider what interventions you might do for each stage or what harm reduction would even look like. So the easy one to tackle here might be harm reduction for her alcohol use. Again, she's in contemplation. She hasn't really made a decision one way or the other. We might be able to use some harm reduction here to help her test the waters. Well, instead of drinking every time you want to relax, what might it be like to drink every other time and to find some other ways to relax in those off times? So, moving away from stages of change and motivational interviewing and harm reduction, I want to move on to this topic about levels of program capacity. So, when we talk about treating co occurring disorders, it's not just about what individual staff do in a session. Programs themselves are categorized by their ability to serve clients with both substance use and mental health needs. And understanding these categories helps us know what's expected of us at JADE and how we compare to other providers in the state. There's three different ways to look at this. There's co-occurring capable programs, co-occurring enhanced programs, and complexity capable programs. And so before we even look at these, which one do you think Jade might fall into just by the language? So we'll start talking about co-occurring capable programs. So this is one that primarily treats either substance use or mental health, but has the training, staff, and policies to recognize, screen for, and address the other. In a substance use setting, that means that staff are trained to identify mental health needs, make appropriate referrals, and adapt treatment plans to take mental health into account. In a mental health setting, it means that staff can recognize substance use issues, offer at least some counseling around it, and coordinate with addiction treatment providers. In other words, capable means that we see it, we acknowledge it, and we can flex our services to support it, even if it's not our primary specialty. And even if we're not the ones doing the treatment, we're going to refer out to make sure that that client gets connected with the appropriate treatment. Now, co occurring enhanced programs take it a step farther. These programs are designed to fully treat people with both substance use disorders and mental health conditions under one roof. They integrate treatment at every level: assessment, planning, therapy, medication groups, and discharge. Staff are cross trained, meaning therapists, prescribers, recovery specialists, and case managers are all equipped to address how substance use disorders and mental health disorders interact with each other. The focus is not just on recognizing or referring, but on directly treating both conditions in a coordinated, comprehensive way. JADE's intensive outpatient program and partial hospitalization program are examples of co occurring enhanced care. We don't just treat substance use and then refer clients elsewhere for their depression or anxiety. We build those mental health needs right into the treatment plan and the group process. Now, complexity capable programs are designed to treat people with the most severe and unstable co occurring disorders. These are clients who may have significant psychiatric instability and severe substance use issues at the same time. And a program that I can think of that does this would be Western Psych CPCDS. These programs often include psychiatric services on site, intensive case management, and crisis services. Staff are highly trained in both substance use disorder and mental health care, often with specialized training in crisis stabilization, suicidality, and psychosis. And they're equipped to manage both conditions when neither is stable. You might want to think of this as the highest intensity of all programs, often inpatient or residential, with round the clock access to both mental health and addiction specialists. So in Pennsylvania, the Department of Drug and Alcohol Programs, or DDAP, and the Office of Mental Health and Substance Abuse Services, OMSAS, sets expectations that all licensed providers must be at least co occurring capable. Act 70, passed in 2021, requires substance use providers to align with the ASAM criteria, which includes providing services that are co occurring capable. And then there's an OMSAS bulletin that came out in 2023, and it made it clear that the state is pushing providers to build co occurring enhanced capacity whenever possible, especially in publicly funded programs. So, what this means for JADE is really clear. We are all expected to be more than just a substance use program. We must demonstrate that our services, staff training, and documentation show not only co occurring competency, but that we can be co occurring enhanced. So there's some practical examples. At Bloom's outpatient program is primarily a mental health treatment program. Their unified protocol for transdiagnostic treatment of emotional disorders is the curriculum that they use in their IOP, and it's a CBT-based program designed to treat anxiety, depression, and related conditions. Bloom can support clients who have a history of substance use if their substance use is relatively stable. So, in other words, Bloom is more of a mental health first program that's co occurring capable, but not designed to be fully enhanced for substance use disorder treatment. Now, JADE's outpatient IOP and PHP programs are licensed substance use treatment, and they integrate mental health care directly into the work. For example, we use the matrix model, which is a structured evidence based curriculum for substance use that also incorporates mental health elements like CBT, relapse prevention, and family involvement. At the same time, our therapists weave in trauma informed and attachment based approaches, and prescribers address psychiatric medications alongside MAT. And this is why JADE is best described as a co occurring enhanced program. So we need to understand these distinctions because it helps staff explain to clients why JADE is different from a mental health program like Bloom. It clarifies expectations. At JADE, every staff member should be ready to recognize and respond to both substance use disorders and mental health concerns, even if that's not your main role. And it also grounds us in compliance. Being co occurring capable or enhanced isn't optional, it's what the state expects, and it's actually just really good client care. Assessment and treatment planning are not just forms that we fill out to check boxes for insurance or licensure. They are the foundation of how we provide meaningful care for clients with co occurring disorders. And when done well, assessment and planning create what we call the golden thread, a clear line that connects the client's story, their identified needs, the ACM dimensions, the treatment plan, the session content, and the notes that we write after each encounter. A biopsychosocial assessment is our opportunity to get the full picture of a client's life, their history, strengths, challenges, supports, and goals.
For co-occurring disorder clients, this means exploring both mental health and substance use together rather than in silos. And the ACM criteria gives us 6 dimensions to structure this work. The first dimension is acute intoxication and or withdrawal potential. The second is biomedical conditions and complications. The third is emotional, behavioral, or cognitive conditions and complications. The fourth dimension is readiness to change or maybe stage of change. 5 is relapse, continued use, or continued problem potential. And then the sixth dimension is recovery or living environment. And these dimensions don't just sit on the intake form. They should flow directly into the treatment plan and later into progress notes. So, for example, if a client reports panic attacks in the assessment, which would fit under dimension 3, the treatment plan might include a goal to develop grounding techniques, and a counselor's group might focus on anxiety management skills. Later, a DAP note or SOAP note would document whether the client practiced those skills and how it impacted their anxiety that week. That's the golden thread. From assessment to ASAM to treatment plan to session content to documentation, everything ties together. And the substance use and co occurring mental health disorders also tie together. It should be very obvious in the ASAM, in the treatment plan, in the DAP notes, in the session content that we're tackling both at the same time concurrently. And assessments aren't just about symptoms, it's also about context, and that's where collateral comes in. Collaterals are outside perspectives that help round out the story. Family input, probation officers, medical records, prior treatment notes, they help us avoid tunnel vision and give a fuller picture of what the client is navigating. Equally important are strengths and cultural considerations, and this is where SNAP framework, or strengths, needs, abilities, and preferences, comes in. SNAP reminds us that every client brings resources and preferences into treatment, things like spirituality, cultural identity, family values, resilience, and creativity. For example, if a client values spirituality, their treatment plan might include connecting with a faith community or using meditation as a coping skill. If a client identifies family as a strength, engaging them in treatment may be crucial. Ignoring these dimensions risks creating a plan that feels generic or disconnected from the client's actual life. Treatment plans should never be copy-paste documents. Each one should reflect that particular client's story. Individualized means the goals and objectives use the client's own words when possible and reflect their unique needs. Trauma-informed means that we write goals that are realistic and sensitive to the client's readiness. For example, explore past trauma is not a trauma-informed goal. A better goal might be develop coping strategies to manage anxiety symptoms connected to trauma history. Strength-based means that plans should highlight what the client is already doing well and build on those skills. Instead of saying something like, stop isolating, a strength-based plan might say, increase use of supported relationships by attending one group per week. One of the most powerful tools that we have is connecting treatment goals to client values. When goals align with what matters most to them, motivation increases. Values exercises can be simple, asking a client to list their top 3 priorities in life, or having them rank what's most important. Family, work, health, independence, spirituality, the list goes on. So, for example, a client may not connect with reducing substance use as a goal, but if they say their children are their top value, we can frame the goal as improve parenting by reducing alcohol use on weeknights. Another client might value independence, and instead of saying manage anxiety symptoms in their treatment plan, the goal could be increase independence by using grounding skills to manage anxiety at work. When values drive the plan, treatment feels less like a set of imposed rules and more like a path towards the life that the client actually wants. So we talked about treatment plans and we talked about assessment, but now we're going to talk a little bit about psychosocial and therapeutic approaches. So what actually happens in the therapy sessions? When we talk about therapy for co-occurring disorders, it's easy to get stuck thinking about just one model like cognitive behavioral therapy. And while CBT is an evidence-based and widely used approach, it's not the only way. And it's not always the right way for every client or every population. At JADE, we are fortunate to have therapists from a range of backgrounds who bring different theories, interventions, and creative approaches to the table. This variety is a strength. It allows us to match interventions to client needs, values, and cultural context. So we're going to look at a few evidence-based models first, starting with CBT. This one helps clients identify and change unhelpful thought patterns and behaviors, especially effective for depression, anxiety, and relapse prevention. Dialectical behavior therapy, or DBT, originally developed for people with borderline personality disorder, but DBT is widely used with clients with co-occurring disorders, and it emphasizes mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness. These skills help stabilize both mental health and substance use. And then we've got some trauma-informed approaches. Therapies like trauma-focused CBT or EMDR, which stands for eye movement, desensitization, and reprocessing, and seeking safety are all evidence-based for people with trauma histories and substance use. But here's an important point. Evidence-based doesn't mean one size fits all. Evidence is strongest when treatment is culturally relevant and responsive. Dr. Jennifer Mullen, in her book Decolonizing Therapy, Oppression, Historical Trauma, and Politicizing Your Practice, challenges us to see that CBT, which focuses on individual thought patterns, may not always be the best fit for clients carrying the weight of systemic oppression and racial trauma. For some, the issue isn't simply distorted thinking, but the reality of living in environments that are unsafe, discriminatory, or traumatizing. In these cases, validating systemic harm, exploring collective healing practices, or incorporating cultural and community strengths may be more effective than focusing solely on cognitive reframing. At JADE, this means that therapists have permission and the responsibility to flex their approach. Whether that's integrating CBT tools, narrative therapy, psychodynamic exploration, art therapy, motivational interviewing, or culturally rooted practices, what matters most is whether the approach resonates with the client and supports their recovery process. And group therapy is one of the central tools in co-occurring disorder treatment. Groups offer connection, universality, that feeling of I'm not alone, and peer support. But they also will stir up relational triggers, moments when clients feel rejected, judged, or unsafe because of past experiences. So, for example, a client might shut down when another member raises their voice because it reminds them of past abuse. Another might dominate the conversation to avoid vulnerability, triggering frustration in others. And a client may feel excluded if their mental health symptoms make it hard to follow the group pace. You can help by setting and revisiting group norms, talking about respect, no crosstalk, and confidentiality. You can also practice naming the dynamic gently. So you can say something like, I noticed when the volume went up, a few folks got quiet. Let's check in about that. What are you noticing right now? You can also normalize triggers as part of the process. These moments give us a chance to practice new ways of responding. When group facilitators handle these dynamics with compassion and firmness, clients learn not just coping skills, but the relational skills that they can carry outside of the group room into other relationships. Many clients with co-occurring disorders have histories of disrupted attachment, relationships in which they did not feel safe, seen, or supported. Attachment-based therapy focuses on creating new relational experiences where the therapist, and by extension the treatment team, becomes a secure base. For clients, this might look like testing boundaries, missing sessions, or pushing back behaviors that reflect their fear of abandonment or rejection. For staff, the goal is to respond with consistency, empathy, and appropriate limits. A secure base doesn't mean giving in to every demand, but it does mean communicating. You matter here. We will hold steady even when things get hard. And this approach isn't just for therapists. Front desk staff, recovery specialists, and nurses all contribute that sense of safety and reliability. When a client sees familiar, caring faces across the agency, they begin to internalize safety and trust. And I want to take a moment to talk about creative, experiential, and integrative strategies. At JADE, we value creativity and experiential work. Clients often express and process experiences in ways beyond words, especially when trauma has left memories stored in the body. Examples can include art therapy using drawing, painting, or collage to externalize feelings that are hard to verbalize, or there's movement or mindfulness practices grounded in exercises like yoga or breath work. You can use role play or psychodrama, practicing new behaviors in a safe space. You can also use integrative approaches like combining motivational interviewing with CBT or art therapy with trauma-informed care to create interventions tailored to the individual. And these approaches are not extras. They are core ways of reaching clients who may not connect with traditional talk therapy. And just taking a moment to talk about some modifications for treatment for specific disorders. So co-occurring disorder treatment often requires adapting our methods based on clients' symptoms or diagnoses. For anxiety, we might want to teach grounding and relaxation skills before diving into trauma processing. We want to avoid pushing too quickly into exposure-based work. For depression, we want to break goals into smaller steps and focus on behavioral activation, celebrating when clients take action, even if it's small steps. For ADHD, we might want to consider shorter structured sessions, visual aids, and concrete tasks helping with attention and follow through. If you have a client who's experiencing psychosis, you want to keep communication clear and simple, avoid arguing with delusions, and focus on safety and trust. And then for personality disorders, we want to balance validation with boundary setting. We can use DBT skills to help manage intense emotions. And in group or individual therapy, these modifications show clients that we see them, not just their diagnosis, and that we're adapting our methods to meet their needs. I want to do just a little bit of an exercise here where we're going to practice bringing principles into your role. So we just reviewed different therapeutic approaches: CBT, DBT, trauma focused care, attachment based strategies, creative and experiential work, and culturally responsive practices. These aren't just tools for therapists. Every single staff member at JADE plays a role in helping clients feel safe, supported, and engaged. So I want you to just take a moment and reflect on the following questions based on your role. You can write down your thoughts or just pause here and consider them. For therapists, how can you adapt your primary therapeutic approach to be more trauma informed? If you mainly use CBT, how might you integrate mindfulness, art, or narrative techniques to reach clients who don't connect with cognitive approaches? Or can you think of a client where cultural or systemic issues like racial trauma might require moving beyond CBT to validate lived experience? If you're a certified recovery specialist, how can you model harm reduction in everyday conversations? For example, celebrating small steps instead of only focusing on abstinence. Or what creative experiential ways can you connect with clients? Maybe through storytelling, shared activities, or community resources? And how can you use your lived experience in a way that helps clients feel less alone and more hopeful? If you're a nurse or prescriber or on our medical team, how can you bring trauma informed lens to medical interactions? Explaining procedures, offering choices, slowing down when a client feels overwhelmed. How can you normalize mental health medications as one tool among many, reducing stigma and encouraging adherence without judgment? And what creative teaching strategies can help clients better understand their medications or health conditions? And if you're administrator or if you're front desk staff, how can your first contact with a client, like a phone call or a greeting in the lobby, feel safe, respectful, and welcoming? Are there ways to reduce stigma through the language that you use? For example, avoiding language like no show in favor for language like missed appointment. What little touches, like tone of voice, remembering a client's name, or being consistent, might provide a sense of attachment and stability? So I want you just to think of one concrete action that you can take in your role this week to support co occurring disorder treatment in a trauma informed, creative, or culturally responsive way. Write it down and keep it as a reminder for how your work contributes to the bigger picture. So, for clients with co occurring disorders, medication can be an important part of recovery, but it's only one piece of the puzzle. At JADE, we emphasize an integrated model where medication therapy, recovery support, and medical care all come together under one roof. Now, it takes some time just to give you the basics of medication assisted treatment, or MAT, and psychopharmacology. There are so many other trainings that go even more in depth on all of this. So, this can just be a jumping off point or a refresher if you've had those trainings before. So, starting with medicated assisted treatment, or MAT, it's one of the most effective tools for substance use recovery, especially for opioid and alcohol use disorders. For opioid use disorder, the most common MAT options, or MOUD, you might hear them referred to as, is buprenorphine, which goes by brand names like Suboxone, Subutex, there's Brixadi, there's Sublocade, those are injectables. And basically, it just works to reduce cravings and withdrawal symptoms and helps clients stabilize daily life. There's also methadone, which is a full opioid agonist given in regulated clinics. It reduces cravings and withdrawal symptoms also. And finally, there's what's called naltrexone, which is Vivitrol in injectable format, or Revia as a daily pill. And this medication blocks the effects of opioids and can be used once somebody is already detoxed from all substances. Now, for alcohol use disorder, medications might include naltrexone again. So we just talked about that one. That's Vivitrol and Revia. For opioid use disorder, can also be used for alcohol use disorder. And it's going to reduce cravings and the enjoyment of alcohol. There's also acomprozate, which is known by the brand name of Camprol. And this helps restore brain balance after quitting alcohol. And then there's disulfiram, also known as Antabuse. And this one creates unpleasant effects if alcohol is consumed. So, on the mental health side, psychotropic medications can be equally important. Common classes include antidepressants. So, there's SSRIs like sertraline or fluoxetine, and then SNRIs like venlafaxine for depression, anxiety, PTSD. There's mood stabilizers like lithium, lamotrigine, valproate for bipolar disorder. There's antipsychotics like risperidone, quetiapine, olanzapine for schizophrenia, bipolar disorder, and sometimes adjunctive depression treatment. And then we've got the anxiolytics, buspirone, hydroxyzine, sometimes benzodiazepines with caution, for anxiety disorders. So it's important for all staff, even if you're not prescribing, to understand the basics. Knowing what medications clients are on helps you support them and notice when something seems off. And in talking about medications, I think it's also important to talk about how we can address stigma, mistrust, and medication adherence challenges. What makes JADE unique is that we integrate all of this care into one place. Medical staff address physical health concerns and monitor the impact of medications. Psychiatrists and psychiatric nurse practitioners prescribe and monitor psych meds and MAT. Therapists weave mental health and substance use treatment together in individual and group sessions. Certified recovery specialists support day to day recovery efforts, bridging clinical recommendations with real world application. And administrative and support staff ensure clients experience a seamless connection between services, from scheduling to coordination of benefits. Instead of clients having to juggle multiple providers and different systems, JADE provides a coordinated team approach. This improves communication, reduces gaps in care, and helps clients feel like everybody is working together. And even though medications can be life saving, many clients struggle with stigma, mistrust, or adherence, or just sticking to their regimen. For stigma, clients often hear messages like, well, you're not really sober if you're on MAT, or meds are a crutch. These messages can come from family, community, or even within recovery groups. And our job is to consistently reinforce that recovery has many pathways, and using medication does not make recovery less valid. For mistrust, some clients have had negative experiences with the medical system, feeling dismissed, over medicated, or not listened to. Trauma informed care applies here too. Explain medications clearly, check for understanding, and invite questions without judgment. And as far as adherence goes, taking medication daily can be tough, especially when side effects show up or when symptoms improve and clients feel like maybe they don't need it anymore. Staff across roles can support adherence by encouraging clients to talk openly about concerns, normalizing the ups and downs of finding the right medication, and celebrating consistency as a success. So, for example, a therapist might process a client's shame about being on buprenorphine. A CRS might share their own story about meds helping them, or encourage a client to take pride in keeping their appointments. A nurse might spend some time explaining possible side effects so the client knows what to expect and doesn't panic. And a front desk staff member might notice when a client hasn't shown up for a refill appointment and gently check in. Every staff role contributes to reducing stigma and supporting clients to stay engaged with their medications. And so, connecting this all together, you might have been hearing this thread of harm reduction as part of a recovery pathway. Harm reduction is a philosophy and set of strategies that help people stay safer and healthier, even if they aren't ready or don't want to stop using substances or change all of their behaviors right away. It's about meeting people where they are and supporting any positive change. This approach is just as important in mental health treatment as it is in substance use treatment. Harm reduction started in the 1980s in response to the HIV/AIDS epidemic, when community members created a needle exchange program to reduce the spread of disease among people who injected drugs. At this time, these programs were controversial, but they saved countless lives and showed that people could be supported in safer use without judgment. Over time, harm reduction has grown to include a broad set of principles: respect for autonomy. Clients have the right to make choices about their own bodies and lives. Any positive change. Progress doesn't mean total abstinence. Cutting down, switching substances, using supports, or stabilizing with medication are all valid. There's dignity and compassion. Services are provided without shame, without stigma, and without punishment. And then also practical strategies fits in here too. Harm reduction focuses on real world tools that reduce risk and promote health. It's not limited to substance use. In mental health, harm reduction may look like supporting someone to use coping strategies instead of self harm, or encouraging partial medication adherence when full adherence feels overwhelming. It's about reducing harm without demanding perfection. And some practical strategies can show up in many different forms. So, one of them might be naloxone distribution and training. We want to equip clients and family members with naloxone or Narcan to reverse opioid overdoses. You can also use safer supplies. Clean syringes, fentanyl test strips, and safe smoking kits reduce the risk of overdose and infection. The use of medication-assisted treatment can also be a practical strategy. So using buprenorphine, methadone, or naltrexone to reduce cravings, stabilize daily life, and prevent overdose. And for mental health harm reduction, it's going to look like encouraging grounding techniques instead of self-harm, supporting attendance at even one group session per week, or normalizing partial progress with coping skills. We can also use peer-led supports. Peer recovery specialists and support groups can provide lived experience wisdom, role modeling, and non judgmental encouragement. For staff, this might mean celebrating small wins. A client who went from using daily to using only 3 times a week, or a client who agreed to start an antidepressant but only takes it half the week, these are still steps forward. Harm reduction recognizes that recovery isn't a straight line. It's different for every person. Some clients may define recovery as abstinence, others may define it as cutting down, avoiding their most dangerous substance, or simply building a healthier daily life while still using. Recovery often includes reoccurrences of use or setbacks in mental health. Instead of treating these as failures, we see them as part of the process. Each reoccurrence provides information: what worked, what didn't, and what might be different next time. Our job is to help clients define recovery for themselves and to stay engaged with them, whether they're in abstinence, harm reduction, or somewhere in between. And I want to touch a bit on the role of continuity of care and case management. Harm reduction and recovery only work when care is continuous. Dropping clients when they miss an appointment or fail treatment breaks the connections that they need the most. Case management is a critical part of this. It's going to link clients to housing, employment, medical care, and mental health services. It's going to help coordinate across systems so that clients don't fall through the cracks. And it's going to support transitions between levels of care. So, for example, from inpatient detox to outpatient therapy. And continuity of care just means that clients always know that they have a place at JADE, even when they struggle. That message, "you still belong here," can be the difference between somebody disengaging completely or somebody eventually finding their way back to stability. When clients feel accepted and supported at every stage, they're more likely to stay engaged and keep moving forward in whatever recovery pathway makes sense to them. And when we think about co occurring disorders, we often focus on the individual sitting in front of us. But research is very clear. Outcomes are stronger when we involve family and support systems in treatment. People are more likely to stay engaged, make progress, and sustain recovery when they have others walking alongside of them. Family involvement is one of the strongest predictors of treatment success. When families or supportive people are engaged, clients are more likely to attend, stay in treatment longer, and maintain recovery. Families themselves often benefit too, learning healthier coping and communication strategies. At JADE, we define family broadly. It's not limited to blood relatives. Family can include a spouse or partner, a sponsor or mentor, a close friend, a neighbor who checks in daily, a coworker, or anyone that the client identifies as a safe and supportive person in their life. If a client cannot identify anyone right now, that's okay, and it becomes a meaningful clinical goal. Recovery is much stronger when clients build supportive connections outside of treatment. If a person's only support is from JADE, they might feel dependent on us in ways that we are not able to sustain long term. Our job is to help them strengthen and grow their own networks so that recovery doesn't begin and end at the treatment center. The goal is not for JADE to be family, but for us to help clients be the resources and relationships that they need so that they eventually won't need us to sustain their recovery. And involving family doesn't mean giving family members unlimited access to information. We have clear boundaries. We do not release information about a client's treatment without written consent from the client. And this includes family members, parents, spouses, everyone. Family sessions are designed to support our clients' treatment, not to give families all the details or let them take control. The focus stays on helping the client feel supported while also giving family tools to better understand co-occurring disorders and recovery. Confidentiality is central to trust. Clients need to know that when family is invited in, it's because they agreed and it supports their treatment plan. Family systems are really powerful. They can be a client's strongest source of support or one of the biggest barriers to recovery. Many families carry long-standing patterns of communication, conflict, enabling, or stigma. And these patterns don't disappear when loved ones enter treatment. In fact, treatment often brings them into the open. Some dynamics that we frequently see include enabling. So that's when a family member may cover up consequences, provide money, or excuse harmful behaviors in ways that protect the addiction rather than the person. There's stigma when families sometimes minimize or shame mental health or substance use disorders, discouraging their loved one from staying in care. There's high expectations or pressure. A family may expect instant abstinence or complete stability, which isn't realistic and sets the client up for shame when recovery doesn't look perfect. There's also codependency. This is when family members tie their own identity and well-being to the client's behavior, sometimes trying to control recovery or make their own stability dependent on the client's. While often rooted in love, it can create stress and tension that harms both the client and the family. When reoccurrence of use or symptoms happen, Family responses matter. Supportive, non judgmental responses can help clients get back on track. Punitive, shaming, or controlling responses often push clients further away. For staff, the goal is not to fix families, but to support healthier dynamics. This might include normalizing that recovery is a process, not an event, coaching families to set boundaries that protect their own well being while also supporting the client, naming when enabling or codependency is showing up, and gently shifting the focus back to the client's responsibility for their recovery. Reinforcing that families cannot and should not be the source of accountability. Recovery is strongest when support comes from multiple directions, both inside and outside of the home. By helping families shift from enabling or controlling patterns to supportive and boundaried involvement, we create healthier environments for the clients and for the family members themselves. And one of the ways that Jade brings families into the process is through our Family Matters group. This group is designed for loved ones of people in recovery, and it gives them a space to learn about addiction, mental health, and co occurring disorders, build healthier communication and boundary setting skills, share experiences with others who are in similar situations, and strengthen their own wellness and resilience while supporting their loved one. Family Matters is not about lecturing families or blaming them. It's about equipping them to be part of the recovery process in ways that are supportive and sustainable for them and for the client. When we support families, we're not just helping them, we're directly improving outcomes for our clients. Recovery happens in relationships and families, however they're defined, and are often at the center of that. Let's get real for a second. Treating co occurring disorders isn't just about therapy techniques or meds. It's also about how we show up for clients who live in very different realities than we do. Housing instability, transportation problems, poverty, racism, stigma, and legal involvement, these are not excuses, they're barriers. And if we don't understand them, we risk blaming clients for things that are out of their control. Recovery looks different depending on who you are. Clients of color carry racial trauma. LGBTQ plus clients may walk in with histories of rejection. Women may face shame about parenting and substance use. Clients from lower income neighborhoods or with legal involvement often experience judgment before they even sit down. If we ignore this, we miss half the picture. If we acknowledge it, we can actually meet clients where they are. So I want to talk a bit about the broken windows theory. And this first came from criminologists James Q. Wilson and George Kelling in 1982. And they argued that visible signs of neglect, like a broken window left unrepaired, trash on the sidewalk, or graffiti, send a message that disorder is tolerated. And over time, that neglect doesn't just stay cosmetic. It can invite more disorder, crime, and disengagement. In the 1990s, the theory was popularized through policing strategies in New York City, often criticized for being used as justification for zero tolerance policies that disproportionately targeted marginalized communities. While the policing side of the theory is controversial, the underlying message about environments still holds weight. What people see around them signals to what is valued. At JADE, we take this lesson seriously, but we apply it differently. We refuse to be another broken system that communicates indifference. Instead, we strive to create spaces that tell clients, you matter and your recovery matters. So that means clean, intentional environments. No clutter, no trash, no forgotten coffee cups. Supplies that are functional, well-kept, and dignified. So we're not using cheap scissors or broken pencils. And we also want to look that rooms are organized and ready every single time. We want clients to know that we've thought about them before they even show up for the day. And this isn't about being fussy, it's about respect. A neglected environment tells clients, we don't value you. A cared for environment tells them, you're worth the effort. When we pay attention to the small things, we reinforce the larger message of dignity, safety, and belonging. And I just want to clear something up really quickly. We have 3 locations for JADE: Southside, Monroeville, and Wexford. All JADE clients belong at all JADE sites. Comments like, that's a Southside client, or they don't belong here, are not only inaccurate, they're stigmatizing and harmful. Wexford, Southside, wherever. Every site serves every client, period. And here's the kicker. Being culturally responsive isn't just saying that you are. It's showing it in how you treat clients who don't look like you, live like you, or fit into your comfort zone. If we say we're inclusive but act otherwise, clients are going to see right through it and they'll disengage. So if we're putting equity into practice, again, every role matters. For front desk, a warm greeting sets the tone. For therapist, bring culture and systemic barriers into treatment planning. For CRS, affirm all recovery pathways, not just the ones that look familiar to you. For medical staff, Talk about meds in plain language without assumptions. And for everybody, keep your space clean and your language respectful. And when I'm saying keep your language respectful, I don't just mean when we're talking to clients. I also mean when we're talking about clients when the clients are in the room. Clients don't just listen to what we say, they pick up on every signal that we send through our tone, our words, and even whether we cared enough to tidy the room before they walked in. At Jade, our standard is clear. All clients are our clients. No matter where they come from, what they look like, or what they've been through, they deserve the same compassion, dignity, and quality of care. Competence in co occurring disorder treatment isn't just about degrees or job titles. It's about the behaviors that we bring to work every day, how we talk about clients, how we document, and how we show up for one another as a team. At JADE, competence means being able to deliver integrated, person centered care and being able to show through documentation and team culture that we are a co occurring enhanced program. The Dual Diagnosis Capability in Addiction Treatment, or DDCAT tool, is what the state uses to evaluate programs like ours. It measures whether we're meeting the mark as a basic, intermediate, or advanced level of competency. And here's what it looks like for us. Basic competence or foundational expectations are assessment. We're screening for both substance use disorders and mental health disorders using validated tools and document both when present. In treatment planning, each treatment plan must address both substance use disorders and mental health, even if one is less acute. In progress note, we're documenting how mental health and substance use disorders interact, not treating them as separate silos. In our language, we want to use person first, non stigmatizing language. How we talk about clients in staff rooms matter just as much as how we talk to them directly. And in team meetings, we're going to participate respectfully, keep client centered language at the forefront. Now, looking at intermediate competence or expanding skills, in assessment, we're doing all of the basic competence, but we're also collecting a substantial history of both mental health and substance use disorders, documenting the client's stage of change for each disorder. In treatment planning, we're matching interventions to stages of change, like contemplation versus action, and explicitly noting how interventions address both mental health and substance use disorders. In progress notes, we're reflecting stage-wise treatment and interventions for both conditions. For medication awareness, we're documenting when clients are prescribed MAT or psychotropic meds, confirming non-addictive options where possible, and note adherence support. In family and peer involvement, we're documenting family education support sessions and peer recovery and integration when appropriate. And then there's the advanced competence with full integration and leadership. In this, we would be using integrated documentation, so assessments, notes, and treatment plans consistently show the interactive course of both disorders. Discharge planning, we would have discharge summaries addressing both mental health and substance use disorders with continuity of care built in. So we want psychiatric follow-ups, MAT, and recovery supports. All of that should be present in the discharge planning. As far as use of evidence-based interventions, we would deliver specialized treatments for co-occurring disorders like CBT, DBT, seeking safety, and trauma-focused models. In supervision and growth, we would be looking at staff to bring complex co-occurring disorder cases, boundary concerns, and stage of change challenges into supervision. And as far as mentorship, we want to look at how advanced staff models integrated care for newer team members by demonstrating high-quality documentation, respectful language, and clinical flexibility. When our staff hit these advanced competencies, the program as a whole demonstrates to DDAP and OMSAS that JADE is not just co-occurring capable, but co-occurring enhanced. And we talk a bit about what it looks like in practice. So in outpatient, competence looks like recognizing that even if a client is only attending weekly sessions, the treatment plan still addresses both mental health and substance use disorders. It looks like documenting small steps, supporting continuity, and showing how daily interventions connect back to their treatment goals. In IOP or PHP, competence means managing group dynamics, integrating both mental health and substance use disorder goals into group content, documenting how each session ties back to the plan, and addressing reoccurrence without shame. IOP staff need to demonstrate more frequent documentation of stage-wise interventions, family involvement, and progress. At both levels, competence is demonstrated in the golden thread: assessment to ACM dimensions, to treatment plan, to session content, to progress notes, to discharge summary. Anybody who's reviewing client charts should be able to pick up a chart and see the story flow cleanly from beginning to end. And at JADE, we have a team of supervisors for every discipline. Supervision and staff meetings are where growth happens for every individual. So what you bring into those meetings matters. You can bring in cases that you feel stuck with and ask, what's the stage of change? Am I matching my interventions to it? You can look at language or bias concerns. Notice when frustration or stigma creeps in and process it before it shows up in care. You can look at skill building goals. Say out loud what you want to grow in, like, I want to get better at harm reduction conversations. You can also bring in documentation questions. If you're unsure how to show the golden thread in the chart, ask in supervision. That would be a great time for it. So, again, supervision is not about being in trouble, it's about keeping you resourced, confident, and aligned with best practices. And co occurring disorder work is rewarding and it's really heavy. Clients bring complex stories, and systems often add stress instead of relief. When we keep pushing without support, burnout creeps in. Burnout isn't just being tired. Research defines burnout as emotional exhaustion, depersonalization, so becoming numb or even cynical, and a reduced sense of accomplishment. In plain terms, you stop feeling like yourself, you start speaking about clients as cases instead of people, and you lose the spark that brought you here in the first place. We also need to name compassion fatigue, and that's the emotional wear and tear that comes from sitting with trauma day after day. Left unchecked, it can look like insomnia, dread about certain clients, irritability, or withdrawing from coworkers. And this isn't a weakness, it's an occupational hazard in our field. Ignoring it doesn't make it go away, it makes it worse. And the flip side is something called compassion satisfaction, the fulfillment that comes from helping others and seeing even small steps as progress. Studies show that compassion satisfaction can protect against burnout when we actively notice it. That means slowing down long enough to register the moments when your work matters. A client making eye contact, showing up for the second week in a row, or telling you that they felt safe here. So, how do we protect ourselves and each other? We're going to look at boundaries. We want to care deeply, but don't carry everything home. Clients deserve your best self, not your most depleted self. We can look at peer support, so lean on your coworkers. Burnout thrives in isolation, but team cohesion is a proven buffer. You could also look at self-check, so watch your tone. If you catch yourself using sarcasm, labels, or sounding bitter about clients, that's your warning light. And for authenticity, clients spot when we're phoning it in. Be real while still professional, and that's going to build trust and help us sustain the work. We can also look at empathy training. Research shows empathy can be taught and strengthened through practice, reflection, and feedback. Higher empathy isn't just better for clients, it actually lowers burnout risk for providers. So here's the bottom line. Well staff are effective staff. Burnout and compassion fatigue don't just hurt us, they harm client care. Staying authentic isn't a luxury, it's part of ethical practice. That means checking in on yourself, checking in on your team, and using supervision and staff meetings not just for cases, but for the health of the people doing the work. So I want to do a reflection exercise here about burnout, compassion fatigue, and satisfaction. So I want you just to take 2 minutes for yourself here. You don't need to share this with anybody else unless you choose to. But starting with a compassion satisfaction check. Think of one recent moment at Jade where you felt like, yes, this is why I do the work. Write it down and hold it in your mind, and notice how it feels to revisit that moment. I also want you to do a warning light check. So think of one sign that burnout or compassion fatigue may be creeping in for you. Maybe it's feeling more cynical in team meetings, dreading certain clients, or rushing through documentation. Name it honestly, even just to yourself. And then when you've done those two things, I want you to take one next step. Identify one small thing you can do this week to address that warning light. It could be asking for a quick consult, taking a real lunch break where you get outside of the agency for a moment, or checking in with a peer instead of isolating. Remember, well staff equals effective staff. Taking care of yourself is part of taking care of clients. So as we're getting to the end of this training, I want us to look at a case example and practice some application. So I'm going to look at this case vignette about Darnell, and then I'm going to ask you some questions about what you're noticing about Darnell. So Darnell is a 29-year-old man who walks into Jade for an intake after being referred by his probation officer. He reports a history of heroin use, currently stabilized on buprenorphine, but says he's drinking to take the edge off. He also shares that he's been struggling with depression since his release from jail 6 months ago. At the front desk, Darnell arrives late and he looks nervous. He doesn't have his insurance card and he mutters, "Probation made me come. I don't even know if it's worth it." The receptionist has to decide how to handle lateness and missing paperwork while still making him feel welcome enough to stay. In intake and evaluation, the clinician screens for both substance use disorders and mental health. Using ACM, they note concerns in Dimension 3, which is the emotional and behavioral dimension, and Dimension 4, which focuses on readiness to change. From a DSM-5 perspective, the evaluator considers major depressive disorder and alcohol use disorder. The billing and administrative staff have to coordinate with insurance, navigating coverage and authorizations for levels of care, while ensuring that services are accessible. And in therapy, the counselor uses motivational interviewing to roll with ambivalence. They might say something like, on one hand, you're saying probation pushed you here. On the other hand, you noticed your alcohol starting to cause problems. Where do you want to go from here? Goals are framed around harm reduction, reducing alcohol-related harm, rather than immediate abstinence. The peer support checks in after group, normalizing mixed feelings about probation involvement and encouraging Darnell to identify small wins. The medical staff is going to review his buprenorphine treatment, screen for interactions with alcohol, and offer education about options for depression. That might be SSRIs, therapy, or maybe a combination of both. Maybe Darnell's also living at John Ryan's house. So at the recovery house, staff notice Darnell isolating in his room and bring it to the team meeting for discussion. In supervision or team meetings, staff are going to consider how documentation reflects Darnell's needs. For example, instead of writing non-compliant with probation, notes might reframe this as client expressed ambivalence about mandated treatment, but identified personal concerns about alcohol use. This one client touches every part of the system. Each staff member has an important role shaping his experience. If you could put yourself in this story, what might you have done differently, if anything at all? Or what might you add on? What's your special sauce that you're bringing to the team that would help make Darnell feel more comfortable and safe at JADE? So you can just pause here and take a moment, collect your thoughts, and think about how you might show up for Darnell. We're wrapping up. I want to just kind of bring it back to JADE. We covered a lot today, from definitions and stages of change to family work, equity, and supervision. As we close, I want to bring it back to who we are at JADE and what this training means for us in practice. First, remember this: recovery is possible. Clients with co-occurring disorders are not too complicated or too difficult. They are people with layered stories carrying both pain and resilience. Recovery is not a one-size-fits-all. For some, it means abstinence. For others, it means cutting back, reconnecting with family, managing symptoms, or finding safe housing. Our role is not to dictate what recovery should look like. Our role is to support client autonomy, helping each person define what recovery means for them and walking alongside them on that path. Hope isn't just a feeling, it's a practice. Every time we greet a client respectfully, celebrate a small step, or keep showing up after a setback, we're practicing hope. At JADE, we like to do things differently. Our model blends collaboration, compassion, and accountability. With collaboration, we don't work in silos. Therapists, prescribers, CRSs, nurses, front desk staff, billing, and administration all work together so clients can experience seamless care. Regarding compassion, we treat every client with dignity, regardless of background, diagnosis, or stage of change. Even when we hold boundaries, compassion comes first. And for accountability, compassion doesn't mean enabling. We hold clients accountable to their treatment goals and to program expectations. That balance, compassion and accountability, is what makes JADE strong. This is what sets us apart from other programs. We're not just a substance use treatment center. We are a co-occurring treatment center. And everything about how we show up reflects that. At JADE, we don't just provide treatment. We create an environment where people with co-occurring disorders feel seen, supported, and capable of change. And this training is not the end of that conversation. It's the start of recommitting ourselves to what makes us different and to what makes us effective. So as you're leaving this training, ask yourself, what does this mean for me in my role? How can I show up tomorrow in a way that reflects JADE's mission of collaboration, compassion, and accountability? And how can I keep myself well enough to keep doing this work authentically? Because at the end of the day, when we're at our best, our clients have the best chance at recovery.